I think we can start now, dear professor.
Yes, for me it's okay.
Okay. Oh, and first I would like to send my greetings to dear Professor Erik Stalberg, one of the eminent and famous tutor in the neurophysiology. He is a professor of clinical neurophysiology at Uppsala, Sweden, and one of the yeah, great eminent in single fiber imaging. And also today we are to complete the previous episodes on the basics and advanced in electroneurography. So I think today one of the best and very interesting presentation talking about the F and A waves, also H reflex, what about the basics, and what about the advanced in readings and interpretations of the findings. I think all we enjoy a lot with this talk and with dear Professor Erik. So we can start now. Floor with you, dear Professor. Yeah.
Thank you. Thank you very much. I'm very happy to be with you again for the invitation. Last time, a few weeks ago, we talked about urography and some of the important things that we do with urography. But we did not discuss F responses and some other things, which I think really are important for every investigation. And urography with motor tests always should include the F response testing. And when we do the F responses, we also see A waves that we shall discuss. H reflexes, first of all, that is reflex and the others are not reflex. H reflexes we use for special conditions and special questions that I will show in my slideshow. So I think we shall start with the video lecture now.
Okay. Just a minute.
Today we are going to talk about some of the late components, namely F wave, A waves, and H reflexes. These are important parts of the neurography investigation. Let's start with F waves. Usually they look like this. We stimulate the nerve distally and record the CMAP first, and then with a higher gain, we see late components. If the gain is, for example, 10 millivolt per division here, it is 0.5 millivolt per division here, since these are very small signals. We repeat this in our laboratory 20 times, in other laboratories 16 or 10 times, but it should be many times to let the individual axons give a chance to elicit an F wave. The physiology behind this is that the axon is activating in antidromic directions after distal stimulation, and it invades the motor neuron that then becomes depolarized, and it stays depolarized for a short while when the axon now is starting to become repolarized and ready for a new impulse. And sometimes in less than 5% of the occasions, the motor neuron can still give rise to a new impulse in the first internode, and the impulse starts in distal direction. How do we measure F-wave latencies? Well, first, one simple technique is to measure the shortest out of 20 recordings, for example. And in our laboratory, we also subtract the distal latency so that, for example, a carpal tunnel does not have an abnormal F response. That is the minimum latency. Another technique that has been used is called chronodispersion, and that is the range of minimum latencies. Here's the shortest minimum latency, here's the longest minimum latency, and the difference between the two is called chronodispersion. The other parameter that we measure in F-wave is number of responses, for example, per 20 recordings. That is called persistence. Minimum latency for the different nerves here, this is median, ulnar, fibular, and tibial nerve, are not very much dependent on age. It is like a nerve conduction study when we talk about older people. A slight tendency maybe, but when it comes to dependency on height, it is very pronounced naturally because we record only latency. We do not recalculate that into some kind of pseudo velocity. So here is the different graphs for the dependence on height. And in the real life, we combine the two with an algorithm. So the median nerve F latency is equal to a constant plus 0.03 times age plus 0.0617 times height and a standard deviation of so and so. And here you can see that the height dependency is not so strong, and here in the leg nerves it's much stronger. The number of F waves per 20 stimuli varies very much between nerves because of different excitability of the spinal cord. Here is typical from the median nerve from 152 subjects, and often in the median nerve we have more than 10 out of 20, but it's difficult to make an exact number here. The ulnar nerve is much more prone to give responses, so that is usually above 15. The fibular nerve does not have so many F responses, even 1 or 2 is normal. And the tibial nerve gives usually more than 18 traces with F responses out of 20. That is because we have responses from each of the small intrinsic foot muscles. We do the study with the patient at rest. We do not activate at all. To have the situation at rest is the most standardized. But we have one exception here, and that is when we study patients in the intensive care unit and they have been paralyzed for a long time and have long inactivity in their limbs. Then the F responses may disappear, but we can wake them up by making a short high frequency stimulation, and now immediately after that the F responses come back. This can be a very important trick to make so that we don't misinterpret the absence of F responses as some kind of neuropathy. Instead, it's a motor neuron excitability that has been changed. Here's a very schematic interpretation of F waves. These are the CMAP, and here are F waves, which, as you know, is a sum of a few axons that give rise to a motor unit potential surface recorded. So here's the variability since we have different axons that are active, and the shortest is here. CMAP amplitude is normal, F amplitude is normal. That is a measure that we usually don't calculate, and the number of F responses is normal. When we have a demyelination, all the F responses are delayed. So CMAP amplitude and F amplitude are normal and persistence is normal, but the latency is increased. When it comes to conduction block, then the CMAP, depending on the position of the block, is normal, but we have fewer F responses. So the CMAP is normal. F amplitude of those that occur is normal, but we have few, a reduced persistence. If we go back to normal now, and then we look at next type of pathology, namely axonal loss, for example, in a nerve trauma, entrapment, or so, we have reduced the CMAP amplitude, and we have fewer F responses because we have fewer axons where F responses can be transported. The amplitude here, at least in the beginning before a re-innervation, the amplitude is normal. So CMAP 50%, F amplitude normal, and number of F is 50% of normal. Now, if we had been able to follow this patient over 3 months, we should have seen that we have reinnervation. That means that the CMAP has become larger, and those axons that conduct, that still survive, they produce reinnervation, and we see complex large F responses, but they are very few still. So CMAP is normal, F amplitude is increased, and that we usually assess visually, and the persistence is low. That is the chronic neurogenic situation. If we have a myopathy, the CMAP amplitude is normal or lowish, and the F responses should be low compared to normal material, but this is always very difficult to measure. But at least it's important to see that the persistence is normal. So CMAP is low, F amplitude may be low, and persistence is normal because all the axons and neurons are there. If we have spasticity, then it's larger likelihood that we produce F responses in each of the axons. So therefore we have a summation of F responses to give this F wave in many of the traces. So the CMAP amplitude is normal, the F amplitude is increased, and the persistence is really increased. It fills up every trace, and there is an increased dispersion as well. Well, these were some simple schematic drawings, and this can be good to think in these lines when we make the interpretation of F responses. Here we have the practical usefulness of the F waves. Since we are studying 2 meters of nerve instead of only half a meter in the forearm or the leg, it is easier to detect real slight changes in the conduction. And many publications have shown that the F wave latency is the first and the most sensitive parameter to detect a slight slowing. Here is the upper normal limit for the patient's age and height. And here you see that all responses come outside the limit. And here is the shortest out of the 20. If we have conduction block in the Guillain-Barré anywhere along the nerve, above or below the stimulation, we do not produce any F responses. So that is empty. Here's another technical situation where we have the Charcot-Marie-Tooth type 1. And first of all, you see a lot of late components here, very pronounced. the velocity is 26 meters per second, so that is half of the normal. And then when we look at F responses with the ordinary sweep speed, we see something here, but it comes way too early. This is not F waves. This is something else that belongs to the CMAP. And now when we change the sweep speed, we see the latency that is very much prolonged. It's 64 milliseconds. And with the conduction velocity, we expect exactly that latency. So remember, with slow velocity, change the sweep speed on the instrument. We have usually looked at the increase in latency and reduction in number, but we have also the other way around, that we may have too many F responses, and that is in spasticity, where many axons give rise to an F response. Here is the normal side in a patient, spastic on the left side, and here you see that many F responses have summated to give this high amplitude and signals and fill up every trace. Here's another patient. Left median and left ulnar is normal, and right median you see more than on the left, and on the ulnar more than on the left. These were very slight clinical signs of increased reflexes in this side. One thing that we should think of is when we judge the persistence. If the amplitude is low because of loss of neurons, then we are expected to find fewer F responses. And here we have the amplitude of the CMAP in number of standard deviations from normal. Lower normal is 2 standard deviations. And if we have good amplitudes here, then we have normal persistence. But when the amplitude goes down and is abnormally low, then we also have correspondingly lower F persistence. So it's a line going through the graph like this. And now we should look at some of the classical motor nerve parameters for different conditions, but we should concentrate just on the F waves. So in demyelination, we have increased in Guillain-Barré and critical illness polyneuropathy. When it comes to persistence, it's reduced in axonal damage in neuropraxia, Guillain-Barré, ALS, all these because they also have low CMAPs. And in severe CTS, when we have low motor amplitudes. Now we should talk a few minutes about the special phenomenon when the motor neuron is giving more than one F wave per 20 stimuli. And we call that repeater F wave. So that is really F waves, and they repeat 2 to 7 times. If it is more, by definition, we then call it A waves. Here is an example. This F wave and this one and this are identical. But here in the other traces you see this is other F waves, these are other F waves. So among the different F waves, we have one that is repeating with constant shape and latency. When we superimpose, we see that better. Here is another way to visualize repeaters. For example, if you see number 2 here, this and this and this is the same. And if you look at number 4, this and this and this is the same. So this patient had many repeater F waves. And when we superimpose, we see that this is just one superimposed. It looks like one signal here, and the others do not show a constant latency. Here we have 3, and you see these 3 are superimposed with a darker line. The frequency of repeaters is very low in healthy. We can have a few in some of the nerves in each patient. That is not definitely abnormal. But when it comes to demyelinating polyneuropathy, ALS, carpal tunnel, and so on, then we have an increased chance of seeing repeater F waves. And that is true for all nerves. This is median nerve. This is for ulnar nerve with another entrapment, fibular nerve for another entrapment. And the mechanisms is not fully understood. Is it just a statistical chance that we give many stimuli and therefore it's a chance to see a few identical discharges from sun axons, or is it really a sign of pathology? Here is an attempt to discuss the latter. If we have an hyperexcitability with increased central influence or less inhibition, it may be that we produce extra F waves. If we have a problem with the Renshaw inhibition that is regulating the firing rate of the neuron, which we have in certain intoxications, and we can also have that in certain neuropathies, we may have extra discharges. Another thing is that if we have a loss of axons, we have a retrograde change in the anatomy and physiology of the motor neuron, and we get a phase of hyperexcitability that theoretically should be able to cause the repeater F wave. I draw that conclusion on basis of the fact that so many of patients with repeater F wave have some kind of axonal loss. And finally, we also have the situation when we have lost other neurons and our main neuron is still intact. If we have lost a lot of neighbors, they in many cases provide inhibition to this neuron. So if we lose inhibition because of loss of neighboring neurons, then this one can become influenced and give extra F responses. Now we go over to something completely different, namely A waves that we see now and then, particularly in tibial nerve. It's nearly normal to see it. We see that in 10 or 20%, and in the other nerves, much less common. Here is an example, and the typical thing is that there are low amplitude, like F waves, low amplitude signals, but these are with constant latency, completely constant latency, and they can occur right after the CMAP, right within the F response is not seen here, or even after the F response. We see them better when we superimpose traces. And the mechanism can be some of the following. Initially, this was thought to be an axon reflex like we have on sensory side. We stimulate here, activate the muscle, and in anterograde direction also activate the muscle via an extra branch. This is not very common to happen at all. Another possibility is that we have a local hyperexcitable abnormal area in the nerve, ionic changes usually. And when we stimulate down here, then the signal goes in the orthodromic direction, but also antidromic, and starts an extra pulse, like an electrical tinel. And the pulse then travels down to the muscle again. There have been other ideas about crosstalk between two abnormal nerves by so-called EFAPs. And another thing that should not be mixed up with A waves is the situation where we have a neuropathy and we have a distinct slowing of the most distal parts of the nerve tree. So we have many slow components, and when we stimulate here, we get a dispersed signal that I will show. Here are A waves in the tibial nerve, and you see it's a lot of them, one here, one here, one here. When we superimpose, we see these, and we also see that it was one here, it was one here, and so on. Here's another where we see one A wave between the CMAP and F response, and here is another that comes just at the end of the F responses. How is it possible that the A waves can occur so late? Well, simply if they are generated in an abnormal nerve with a slow conduction, then it's very easy to understand that they can have any latency. How can we differentiate between the real A waves generated in this way and the late components that occur here? Well, one simple way is to move the stimulus 3 centimeters more proximally. When you have an A wave and you move proximally with the stimulator, the CMAP comes a little later and the A wave comes a little earlier, so they go together. If we have the same thing here, we stimulate and then more proximally, then the CMAP and the late components follow each other. They move together. I will show a few examples. Here you have the CMAP, and here's the takeoff, and then we move the stimulus 20 millimeters, and then the latency is longer here, but for the A wave, that is now all of a sudden shorter. Here's takeoff, here's takeoff. Here's an other situation where we have the late component here. It really looks like an A wave, and we do the same trick. We move the stimulator in proximal direction so that the CMAP comes a little later. But here you see that also this late component comes a little later. So in contrast to my previous slide, this is now a CMAP satellite. It is really not an A wave, but it comes from the slow conducting very distal nerve twigs. Here is another situation where you have a patient with CIDP and you see a fantastic amount of stable components. When we superimpose, we see the stable components here and the unstable F responses out here. So what are these? Are these multiple A waves or is it something else? Well, by moving the stimulator from here, which is at the ankle, with a lot of late components here, to the knee, we see that the whole thing has changed together, the CMAP and all these other late components. So these are not A waves, but these are CMAP satellites. Then we can go over to the H reflex. That is a reflex, and the other two that I've talked about, F response and A waves, are not reflexes. And the H reflex is studying both the sensory and motor axon conduction and the motor neuron excitability. In the F wave, we measure the motor axon, and the A wave is also signed from the motor axon. Here for the H reflex, we measure latency and amplitude in relation to the CMAP amplitude. And here is the mechanism for the H reflex, where we stimulate the nerve here with a very slight stimulus, and that impulse goes both in distal direction and in proximal direction. In the retrograde way with the sensory nerve, it is then jumping over to the motor neuron, and that provides a motor response. And by stimulating very carefully, we are able to stimulate just the sensory, and therefore we just get this response. We increase the stimulus a little, we see it higher amplitude. And then when we increase the stimulus even more, then we also start to stimulate the motor nerves in both directions. And this motor nerve that goes in the antidromic direction will meet the signal that started here and came out as a motor. It will be collision right here. So with increasing stimulus, we start to see M wave, and this one will be collided and disappear. And finally, we only have the F responses. When it's the F, then we stimulate motor and get the response from the motor. So it's a motor-motor. This is a sensory motor. The H reflexes can be done mainly for a few levels of the spinal cord, both in S1 and in C6, C7. Here is H reflex in tibial nerve, slight stimulation. We start to see the response here. Here are the late responses, and then we increase the stimulus strength so that the CMAP increases, and you can see how this disappears more and more. And here is for the arm to flexor carpi radialis, the same phenomenon. These are a little more difficult to see, and we don't see them in 100% like we do in the leg. So therefore, it's a little more questionable how to interpret the absence of an H reflex in the arm. Here is another, the same patient, the other side. Here is just one case I wanted to show where we make the nerve conduction in a patient with a myelopathy and a neuropathy. He had this very low and abnormal motor response. And with the same gain, we saw the late components that were higher in amplitude than the CMAP. And that is not possible that this is an F response. It must be something else. And when we stimulate with little stronger, we get the little higher amplitude here, and the late response disappeared. This is what it looks like when we repeat the stimulations, and you see that the pretty constant shape of this phenomenon. And here is when in this patient I reduced the stimulus strength and the CMAP disappeared, and we still have the late responses. So this is H reflex in this muscle that was spastic. The protocol is that we stimulate the tibial nerve with low stimulus strength, a long duration to favor the sensory nerves, and to make a very low frequency, because we have something called habituation where reflexes disappear. That is not true for F response, but for H reflex. We record over soleus or gastroc, and is useful for F1 radiculopathy and also polyneuropathy, myelopathy. And the reference values, you can either use published values that are related to height and age, but in unilateral cases, in unilateral S1 radiculopathy, you can use the side asymmetry to guide. The asymmetry should be less than 2 milliseconds if you use exactly identical electrode positions. This is for the arm, median nerve, flexor carpi radialis, and otherwise the same thing. We also have one more thing regarding reflexes, and that is in some laboratories they use so-called T waves. That is the patellar reflex that you simply not only look at, but you record the response from the quadriceps femoris. And here is at rest, where you get the small response, and with slight activation, you get the facilitation and much higher amplitude and little shorter latency. This can be done in any muscle where you do your um, studies with the reflex hammer. Here are some summary of the A wave, F wave repeaters and H reflex. The CMAP satellite is late components that follow the CMAP when we change cathode position. So that is a part of a neuropathy. A waves, they are generated anywhere along the peripheral nerve, indicating a local axonal hyperexcitability and has nothing to do with the motor neuron. It starts in the axon and varies in latency. F waves come from the motor neuron. For each neuron, they do not occur so often, probably less than 5% as we have measured. Repeaters, that are repeater F waves, so they come from the motor neuron and they come 2 or 3 up to 7 times per 20 stimuli. The latency is naturally the same as the latency. A waves come more than 7 times per 20, usually up to 100%. And H reflex that we look at when we have spasticity or proximal sensory involvement. Same latency as F waves, constant shape, and we see them with low stimulation when they have low CMAP amplitude. When we increase the stimulus, then they disappear, and it must be a slow stimulation rate. So the difference again between them, A waves is from the peripheral nerve, probably ion channel trouble. F wave, motor neuron, and looks at motor neuron excitability. And H reflex takes care of both the sensory and motor axon conduction and the excitability of the motor neuron in, for example, central disorders, but also useful in some radiculopathies.
Okay. Really, thank you for this amazing talk, as usual, dear Professor Eric. So I think I have a lot of questions about these topics. First, what about the some debates on the position of the stimulating electrode during F-wave recordings? You prefer to use the cathode toward its antidromic toward the cathode also recording, or to reverse the stimulating bar during the F-wave production?
Very good question. Very common question, and that has been discussed a lot. And many people, including ourselves, have been looking at this carefully. If we do not change polarity, because we think that also the impulses that are going in the antidromic way are produced at the anode, also if anode is more distally, because the cathode, sorry, I'm saying wrong. It starts at the cathode that we have distally. the anode is not blocking much of signals at all. So all impulses, if we have normal stimulation strength, 20%, but if we increase the stimulus to 200% or 300, very, very strong, then we start to have activation from anode.
Thank you very
Not
much.
in the normal.
Yeah. My second question, some in spasticity, spinal cord lesion, we use some equations like that, F and M ratio, and also H and M ratio. What about the impact of this ratio and its values also?
Yes, that is one way to look at the excitability. When we do the normal test of F wave of H reflex, the H reflex is often 50% of the normal, so the ratio is 0.5. But if we have spasticity, it can be even much higher. The M wave may be normal and the H wave may be much higher than the M wave. So that indicates spasticity. And some people have used this to follow the development of spasticity and to make a grading of that. So that is a useful index. In many EMG machines, you get that index automatically.
Yeah, great. About persistence, it must to be half percent. Yeah, the number of persistence of F wave, it must to be half of the shooting, such as 10 shot or 20. It must to be 10, 10. It must to be 5 or something else.
Well, that is just pure statistical discussion. So it is. It is not so easy because for each sweep it is often more than one neuron that gives an axon. So if we lose some axons, the persistence goes down a little, but not exactly statistically. But just that we should all remember that if we have a very low CMAP amplitude, for example, half, then it is very likely that we have a lower number of F responses.
That's great. Can we obtain F response from any nerve, such as radial?
From any motor, we're talking about motor nerves.
Yes,
We
true.
do not get it from sural or anything. It's only motor. But for example, we get it also in facial nerve and all motor nerves.
That's great. Okay, dear Professor, fibular F wave, it's challenging a little bit. We cannot and easily to obtain an F wave from perineal or a fibular. So we can use some reinforcements. You suggest to do routinely F wave for perineal or fibular, or can do just tibial F wave?
Absolutely, we can do just the tibial, but I don't think it costs so much pain or time to make the fibular also. But as you say, we have very few F responses in fibular. So if we have 0 there, we don't know, is this normal or not? I agree, it's much more difficult to say anything, but latency you can trust, but not persistence.
Great. In H reflex, dear Professor, we can use H reflex from different positions. Such in S1 radicalopathies, we can use it in prone, and some a little bit in sitting, some a little bit in standing. And we see what the morphologically changes in H reflex and do some exercise or something like that to decrease the pressure on the S1 root. Can you prefer these techniques, or I think the position of the spine can change the morphology of the H reflex?
Very interesting idea and question. I have not been involved in that, and I don't know literature that has been doing that carefully. But maybe when we move the body in different directions, and then we also have different input from skin and from joint. So I should not be surprised if the H wave changes when we have an atypical body position.
Yeah. What about the recording H reflex from rectus femoris? Can you get some clue for do a best recording from rectus femoris?
From
Rectus femoris H reflex
yeah,
L2 and 3 roots.
from which muscle?
Rectus femoris, quadriceps.
Quadriceps, yes. Um, uh, it is very funny that among the quadriceps muscle, you say in literature that soleus should be the most typical, but sometimes we get more better response from the medial gastroc, or even best in the lateral gastroc. So if we get a bad response from soleus, we try lateral and medial gastroc.
That's great. I have three questions and the Q&A box. First, how to differentiate repeater F wave from E waves?
Um, F F wave always have a relatively constant latency, and you know the normal values for that depending on height and um, age. The F waves vary in shape, amplitude, latency, but the A waves, the did I say it wrong? The F wave vary in shape
Yeah,
and have a certain latency. A waves are stable, absolutely stable, and can have a latency that is between CMAP and F wave, right inside the F wave, or even after the F wave. So I think latency is typical for F waves, and the stability of shape and latency is typical for A wave.
yeah, great. Second question, in restless leg syndrome, what about the HM ratio values? It is normal or higher or less or what?
I'm not sure.
Yeah. Third one, any significance in measuring the H reflex in brachioradialis? Brachioradialis, H reflex.
Yeah. Um, if it is significant to measure that in ALS, you say?
Can you record the H reflex from brachioradialis muscle?
Yes, yes. You can do that. The in normal, it is easier to measure the H reflex in flexor carpi radialis and in a quadricep. But as soon as you have spasticity, then you can obtain it very easily in many other muscles. And in babies, you get it easily in many muscles. That is normal in babies.
Great. In such cases, in motor neuron disorders, some has an overdose of mestinon. So we can say in F wave remote potentials. It's differ a little bit from the satellite CM or the C.
Uh, I did not hear exactly the last, but with mestinon, first of all, mestinon and motor neuron, theoretically it has some positive effect, but not so much. But I should like to say like this: overdose
Yeah,
of mestinon
yeah.
is better seen with repetitive nerve stimulation. If you do repetitive nerve stimulation, you see a low initial amplitude and decrement. And when you then activate, you do not get facilitation with increase in amplitude, but you get lower amplitude immediately after activation. So that is better a way to detect overdose.
Yeah. Sorry for this lot questions. So I think the last one. Do repeater F wave the same morphology, and what about the significance?
The the you say significance of F waves?
No, repeaters.
Huh? A
Repeat. Yeah.
repeaters.
Yeah.
Repeaters is coming from the same neuron all the time, and therefore the latency is constant and the shape is constant, which is different from the normal F waves that are is summation between different axons each time. But for repeaters, it's coming from the same axon all the time.
So last one. What about the specificity of F wave in a man?
Um, and none of these things that we have talked about today is specific for a given disease.
Hmm.
So I just leave it like that. It is not specific, but it is a red flag if we have a lot of A waves in other nerves than tibial anterior. It can be in tibial nerve. It typical the first 2 weeks of Guillain-Barré, and the F wave delay is typical of polyneuropathy. But I should not say that any of them can give us a diagnostic label.
Yeah. Okay, at the end of this amazing talk, as usual, dear Professor Eric, hope all to be safe in this era. And thank you. Yeah, a lot of many thanks for your effort, continuous learning for all of the interest in neurophysiology. So please accept my greetings and thanks again. Hope to share another presentation in another interesting topic. Thank you, dear Professor.
Okay.
See you
Thank
soon.
you very much for listening. Thanks a lot.
Bye bye. Okay.
Bye.
Okay, dear attendee, I think we have another talk in Tuesday with Professor Mishra. He will talk about the electrodiagnostic and clinical abnormalities in myasthenia gravis and Lambert-Eaton and botulism and all the neuromuscular junction pathology. So I think it's very important to join us in the next Tuesday. So see you soon. I think my recordings will be available. I think tomorrow. You can repeat, visit this website of at Facebook, my association. So I think continuing to share us in a lot of interesting tutors. Please follow us and share us always in continuing education. All hope to be safe. Okay, goodbye. Assalamu alaikum wa rahmatullahi wa barakatuh.